Hi, I'm Dr. Diana Hill. Thank you so much for joining me with Your Life in Process. And if you want more, if you're interested in applying these processes to your daily life, join me at my membership, More Life in Process. At More Life in Process, you will get meditations for you to practice at home. You'll get extra bits from the episode that maybe got recorded after the fact. You're going to get PDFs and handouts, things that you can use to apply your daily practice to your life. And I can't wait to see you there. $5 a month, $50 for the year. You can go to yourlifeinprocess.com to sign up. So I'm actually going to go first to something that you talk about in the book, which is small talk and big talk to build our connection. And I actually want to start there before we even talk about any of the other stuff, because you've done a little bit of research with medical students around this, of going into big talk, which is questions that are deeper questions than just like, how are you doing? And some of the questions that you suggested, I'm going to ask you of to get started.
Wow, turning it on me. Great. I don't even remember what they are.
Okay, I'm going to ask you two to get us started. So the first one is, if you could wake up tomorrow having one quality or ability, what would it be?
So, this is a good one. Damn, this is a good one. I think it's something I think of that I'm actually working on in my practice, and something that I'm hoping that I'm working on cultivating. And that's really just being able to have the person that I'm with feel grounded and comfortable to be themselves, and just to help the other person feel that this is a total judgment-free zone, that we don't have to pretend, we can just be honest, and that they don't have to be afraid of pretending there's something that's not genuine to who they are. So I think it's something I'm working on, and part of it is demonstrating that and exhibiting that myself.
Nice. Well, that's a great way to start. If you can do that as a doctor, if I could do that as a therapist, or we could do that as friends or teachers, or it's a beautiful quality to welcome people. Okay, I'm going to ask you one more big talk question, which is, if you could change anything about the way you were raised, what would it be?
Yeah. So this one's always tough because, of course, the bones I have to pick about my childhood are probably exactly what led me to where I am today as a psychiatrist and positive psychology practitioner. But I think as a child, I was often sort of the therapist for my family, and I was the baby of the family. And sometimes I wish I didn't have to have that responsibility. And it was probably some give and take of what I put forth in my family as someone who wanted to make peace and have everyone get along. And the more you play that role in a family as a child, I think the more you're called upon to play that role. And I don't know that I would change that, but I wonder who I would be today if that was not something that was a role that I played in my early life.
The peacemaker. Mm-hmm. Of the family role?
The pacifist, yeah. Absolutely.
The pacifist, yeah. Okay, so we already know a lot about you, even though I read your bio, but even though we haven't really fully gotten to know each other yet, just by asking two pretty big talk questions. Why do that? Like, why is it important to ask questions like that of each other?
Yeah, so this is not to say that small talk is not important. I think when we wrote Choose Growth, it was in the midst of the COVID pandemic, when we were all fairly isolated, and social support and connection became this thing that we became a lot more ambivalent about, because it actually was something that was kind of dangerous for our immediate survival with a virus all around. So I think a lot of us became a little rusty at having these conversations because we spent so much time alone and so much time behind a screen, and not really in the sharing space and sharing another person's real essence in 3 dimensions. So I think we got really rusty with small talk and big talk. I think this is something that really went away for lots of people. They didn't have opportunities to connect deeply. And so there's a very famous study from 1995 by couple, Aaron and Aaron, and they actually brought people into a laboratory and gave them predetermined questions to ask one another. And these were strangers, and some of them were randomized to this like deep, big talk condition. And the others were randomized to just like this small talk, like, tell me what TV shows are you watching, condition. And they found that the participants in the big talk condition felt much closer with one another at the end of the 45 minutes or so of asking these questions, and really felt that they understood each other better and felt a deeper sense of intimacy with one another. So in a time in our lives when intimacy was something that was so fragile and precarious, we wanted to introduce people to this way of being with one another, getting past some of these surface level questions of, what TV shows are you watching? And, what new hobbies are you building during COVID? But really getting into some of the deeper questions of our being.
Yeah. How did it feel for me to ask you those straight off the bat?
Well, I now, of course, I want to ask them to you back. I hope that's okay. They're questions that, like you said, they really make you think and really get to the heart of what matters most, not just like, how am I filling my time? And, of course, now I would love to, is it okay to turn them back on you and ask you these big talk questions? Because what happens is, what I found is that in small talk, it's often like, okay, I'll go and then you go. And I'm sure there were lots more follow-up questions we could have gotten to in real life if we were having this conversation without the podcast, that we would have gotten deeper and deeper into. And it's not just a back and forth exchange, but that becomes the fodder to really delve deeper and understand one another on a more human level.
Yeah, absolutely. Well, you're such a psychiatrist of wanting to ask the questions back. Yeah. And there were so many follow-up questions. This is what we do for a living, right? It's like, is you start with one question, which leads to the next, which leads to the next, and they're never ending. And you feel, at least I feel, deeply connected to my clients, and sometimes in some ways more than some of the people in their lives feel towards them, because we don't ask these deep questions in just the vernacular of friendships or even in couples.
Totally.
So, yeah.
And that was a big part of writing this book. There are a lot of questions. It's a workbook. So it's really about getting our readers to think about things that probably human beings in their lives, short of a therapist or a coach, are not asking them. And when people aren't asking us these deeper questions, many of us are not asking them of ourselves. And often the questions we ask, the questions I ask my patients, the questions I've read and tried to grapple with in this book are what orient us toward our values, and really to examine, how are we living our lives? And, why aren't I, if there's a skill that I want to have and I could wake up with it tomorrow, why aren't I working on that skill? And to really get us to orient towards more deliberate living and being.
So how you answer some of those deeper questions illuminates pretty quickly what your values are. And then once you uncover those, then you can start living from those. And when you see other people's values, it also makes you feel connected to them, because we often have similarities in some of the things that are most important to us. We may not have been a peacemaker in our family, but there may have been something else in our upbringing that was challenging, that impacted who we are now or the career path that we've chosen.
So what skill would you want to have tomorrow?
Well, the skill that I would love to have, I would love to be more of a physical risk taker. I am such a scaredy cat. I don't like going fast down steep things. I don't like being in any way physically risky. And the reason why that is a skill that I want more of is because my kids are growing up, and I want to do activities with them as they are learning them. I want to participate and be the type of mom that's like all in. And sometimes my fear gets in the way of me fully showing up. So I wish that was just easy for me. It's not. And I'm increasingly taking risks, but that is something I wish would come easily to me.
Oh, so that is so cool. And what better motivation than to have kids be the ones to teach you some of that, to be a little more fearless. Could I ask you a question? Do you like ride a bike? Like, have you been on wheels? Is that
No, I won't even. So my dad was really into like racing bikes and bikes all my life. So I became a runner. And I was
Feet
like,
on
that
the
was my
ground.
rebellion.
Yep.
But it was my rebellion from him because early on he wanted me to do stuff on bikes, and it was so. No, I have not. I mean, I'll get on like a bike. I had like a beach cruiser, but these are the things that we get into our comfort zone. And you talk about this in Choose Growth of how to expand our comfort zone. So for me, it's easy to have deep conversations with people. That's actually my
Yep.
comfort
That is
zone.
your comfort zone.
I'd love to talk to
Totally.
you about that all day. But if you ask me to go skiing, I'll say no. But this expansion of our comfort zone, not only in our relationships, but in other areas, like in areas of mastery and the importance of expanding our comfort zone. And the other question, I forget what the other one was. What was the other one?
If you could change anything about your upbringing.
Oh, that one's an easy. My mom grew up in Peru and is fluent in Spanish, and I am not. And I wish that I was fluent in Spanish. I wish she spoke Spanish to me.
Yo también.
All childhood. It's important. So that's what I wish were different. But let's talk a little bit about, so the book, it starts with, anchoring yourself, and then you move through these different chapters that it is a workbook. So you're going to be, writing things down, trying things out. The first thing you talk about after anchoring is connection. And then you go into healthy self-esteem, which, the word self-esteem rubs me the wrong way a little bit.
It rubs a lot of people the wrong way. And it's actually one of the interesting debates that Scott, my co-author, and I have. And I was really adamant about bringing self-compassion into this chapter, because to me, that's a much more helpful construct, because self-esteem can be quite fragile. I'm curious what your bone to pick with self-esteem is.
Yeah, that's the bone to pick. Just some of Neff's research on self-esteem versus self-compassion, and that sometimes self-esteem is bolstering yourself up, comparing yourself to others, saying, I am good, I am special, and therefore making yourself separate and not having that common humanity, which leads to the underbelly of that, which is when you don't do well, you feel terrible about yourself. I am worthless. And that's where I was interested in your discussion around narcissism and this distinction between grandiose and vulnerable narcissism. I'd never heard that before. So yeah, tell us a little bit about how you're conceptualizing self-esteem and how it relates to narcissism.
Sure. So I think exactly what you said, the type of self-esteem that is derived from the negative comparison of others, building ourselves up to put ourselves down, is really a derivation of narcissism. It's kind of masked self-esteem. And so, of course, we use the self-esteem because this is the construct we use, the sailboat metaphor throughout the book, where we highlight the common human needs, is really an extension of Abraham Maslow's work on the hierarchy of human needs. And this was one of the needs that Maslow talked about. So we have extended it to our work and really brought in the self-compassion piece. So, at the core of self-esteem, of healthy self-esteem, there are two pieces to it. And those are a sense of self-worth, that I am inherently worthy, and the sense of mastery, that I can go out and do the things that I want to do. Self-worth is tricky because often it develops early in childhood when a loving caregiver essentially tells us, well, not necessarily verbally, but indicates through behaviors that our needs are as important as theirs and that they will tend to our needs. And while I don't think anyone's sense of self-worth is absolutely set in stone, so much of that comes from our pre-verbal early life experiences. And it can take a lot of work to rewrite and to really bolster a sense of self-worth that was not afforded to us early in life, whether it was because of, adverse childhood experiences, neglect, abuse, and so on. Mastery is also tricky because it's much more within our control, and it is about, we can set ourselves up to master tasks, to follow our ambitions and our passions. But so often, of course, if we're in any field, in any discipline, in any real experience with life, failure is a part of growth. And if someone's whole self-esteem is contingent upon a sense of mastery when things don't go well, like you said, you fail a test or you don't do well in a presentation, that whole concept can really shatter beneath us. So I absolutely love Kristen Neff and Chris Germer's work on self-compassion. And like you said, I think it's a really great alternative to just focusing on bolstering our sense of self-worth and mastery towards meeting ourselves where we are at and giving ourselves that love that we would more easily give to another person, and recognize that we are part of a common humanity, and that we can even be mindful when we fail, when our self-worth is not really giving us what we need and bolstering us. So, narcissism is really the unhealthy regulation of that need for self-esteem. And that can result in, the classic sort of chest-thumping narcissist, the grandiose narcissist, what we often think of when we think about a narcissistic person in our lives, someone who's quite overt about touting their accomplishments. And then the more fragile type of narcissism it's less overt, but it can be really more insidious. Someone who's always, putting their own needs first, but maybe do it in a sort of quieter way. Someone who may really say that they feel like an imposter in order to shield themselves from, if they are not to succeed, they'll just blame it on, they're more likely to say they experience imposter syndrome. And it's really actually the one of the unfortunate things about that way of regulating self-esteem is it's highly, highly correlated with depression and anxiety and other mental illnesses.
So you have a checklist in here comparing grandiose narcissism to vulnerable narcissism. And I think a lot of people are going to endorse some of these. So if you're endorsing these, it doesn't mean you are a narcissist, like you're categorically DSM diagnosed narcissism. But there is a distinction. Grandiose narcissism are things like, I like being the most popular person at a party. When people judge me, I just don't care. I deserve to receive special treatment. It's often the narcissist that we think of that drives us kind of nuts, right? But then there's the vulnerable narcissism that you were saying is associated with this imposterism, is I feel as if I need compliments from others in order to be sure of myself. I like to have friends who rely on me because it makes me feel important. I often fantasize about being recognized for my accomplishments. It does have that kind of vulnerability to it of almost like neediness, like I need to be special, I need to be acknowledged, I need to be seen to have a sense of worth. And I would imagine that in medical school and in your medical training, you got a whole lot of both going on.
A whole lot of all of those things going on. And that I think that need for external validation becomes so paramount to the identity of a doctor. And because it's always about the test, studying for the test. And all those years before we really get to our patients, it becomes about these larger, like the approval of our supervisors, of our attendings, the approval of our residents. And, I think we can miss the compass of what we really want is to do the best we can for our patient. And I think the part of the way, we're veering off how this is applied in the medical realm in my work with healthcare workers is, we have to recognize that our medical training can really actually foster and select for some of these characteristics. And once we're aware of that, we can actually do something about it. And we teach in one of the programs I run, we teach self-compassion and help us really unpack some of these questions. But in fact, a lot of these things are quite selected for in our medical training.
Yeah. Well, even the concept of self-compassion, I have to say, we pull self-compassion out of compassion. It's like pulling out, one ingredient of kale out of the whole thing of kale, because self-compassion is also about compassion, and it's all the above, right? So for some folks, actually, the best intervention for their narcissism is to have compassion for another. And then for some folks, the best intervention for their vulnerable narcissism may be to receive compassion from another. And then for others, it may be to give compassion to yourself, but they're all kind of working in the greater concept of compassion. But I do see, with something like in medicine or going to see a physician, there's so many times when I've gone in to see a doctor and it has felt so one way. It has felt like you're not even, like you didn't ask about anything about other things that may be going on with me that may be contributing to my sleep problems or my whatever it is I'm coming in with. And then you're kind of slapping your solution on it. And you have such a different approach as a doctor, and are really passionate about taking a different approach, which incorporates some of these concepts from the book, like self-compassion and compassion as well.
Yeah, well, it makes sense that, in medical school, it's the whole biomedical model actually is all about problems and sort of understanding problem, understanding solution for problem. And we don't learn really anything about psychology or like positive psychology, or we learn about empathy in medical school and the importance of validating our patients and listening. But I think because we're so problem oriented, we lose this whole side of the individual of how we can actually tap into what's right with them in order to work on whatever it is that they're coming in with. We're really looking at like the -10 to 0 part of the human experience without focusing on, right, tell me what's going well. And then when we're listening for those things, what's going well in your life, who's in your life, what's giving you a sense of meaning and purpose, what keeps you going. It's those things that often have the clues for how we can help you with whatever is going wrong. And it's just not something that we do very much or learn very much. And I'm kind of on a crusade to even the scales and move away from the biomedical model towards what the biopsychosocial model that was proposed by Jordyn Feingold. And we're still not there yet. And it kind of perplexes me, but
and from the psychologist's perspective, we are so disconnected from how biology may be impacting what's going. We're so focused on the psychosocial, we've just completely left out the biological. So things like the microbiome and the gut-brain axis, and how maybe this person is having side effects from their medication, but we're pathologizing it and calling it anxiety, but it's really a withdrawal symptom from going off of a medication, or nutrition, those things that we aren't doing a good enough job paying attention to in the field of psychology. So that's why I love talking to someone like you, because we're kind of trying to meet in the middle here of learn from each other and expand our view beyond just what that really rigid training was, and not just only seeing everything as psychological or everything as biological, or everything as a problem. So you have something called the REVAMP model, a sort of a model that you've developed, that when you go in and you are training physicians, or you yourself are going in and working with a patient, that addresses more this biopsychosocial perspective. What's involved in that?
Yeah, absolutely. So before medical school, before I ever became a doctor, I did my master's degree in applied positive psychology, which is all about well-being and understanding what is right with people. And what I learned, because I knew I wanted to be a doctor and apply these things within medicine, I was looking for like a sort of narrow perspective on how we could apply positive psychology in medicine, because obviously the applications are vast. But what quickly became really apparent to me was that physicians themselves were really suffering with mental illness and burnout, and that all of these things, all of the badness among physicians, and then by extension, many of our patients, was very well defined. Like, we really understand what burnout is, the syndrome of emotional exhaustion and depersonalization and low sense of personal accomplishment. And we have DSM criteria for all of the mental illnesses. But when it came to understanding what was going right and what well-being meant, there was not a whole lot of consensus in the field. So I was really excited about actually looking at many different theoretical models of well-being and coming up with one that I thought made a lot of sense to apply within healthcare. So many of your listeners may have heard of the PERMA model, which is Marty Seligman, the father of positive psychology's model, that came out in 2011, I believe, in his book Flourish. And that is stands for positive emotions, engagement, relationships, meaning, and accomplishment or achievement. And that is very well recognized in the field as a model of well-being, and it's been operationalized and there are scales to measure it. But what's missing from those 5 ingredients is a sense of physical health and vitality. So, of course, in healthcare, that's a huge part of what well-being means. So what I did was a little bit of a reorganization of PERMA and centering vitality in this construct, which a lot of now before me and now since many in the field agree is really a more comprehensive model, and it's called REVAMP. What I love about it is it starts with relationships, the single most important predictor of well-being and life satisfaction across the lifespan. So really the connection piece, our need for connection, and in there is that need for love, which in our book we talk about as a higher order connection, and it's where I talk about the relationship to the self or self-compassion. Then there's the engagement piece. So thinking about what gives us a sense of flow in our daily lives. How are we using our strengths in day-to-day life? Vitality, that sense of energy we have to tackle our day-to-day tasks with vigor, how we're sleeping, what we're nourishing our bodies with. And really, this is where I talk to my patients about, and doctors about, like the mind-body connection and how these things are deeply integrated and we really can't separate them. Then after vitality is accomplishment, our sense of achievement, and really rethinking our accomplishment as being non-zero sum. It's not that someone else has to fail for me to succeed, that sort of narcissistic way of putting ourselves ahead, but thinking how we can work with one another to rise the tide for everyone. That sense of meaning, what gives you a sense of purpose? How are you part of something larger than the self? And finally, positive emotions, that daily lived experience of the positive. And so these 6 buckets are something that I really try to, especially in an intake visit and then to follow up with my patients, I want to know about what these elements are in my patients' lives. And when I teach doctors about this, I do something called a revamp or a well-being review of systems, where we go head to toe and we think about all of these things in their own lives so they can talk about them and feel just how different it is than what we actually do in a medical visit, where we are so attuned to diagnosing and fixating on what's wrong.
Yes, and it's probably closer to traditional medicine, where it's much more about your whole life and your family and all the different components that make up you, not just, the GI problem that you're coming in with or the back pain, because we all know that your GI problem and your back pain is related to all of that. And you've talked about and written a bit about embodied cognition, and what we're coming into the doctor for and with often is a reflection of what's happening in our life. And that these are not we can't really separate them out as much as we want to, in particular, the gut-brain axis, because so much of what's happening in our gut is related to our nervous system and our stress and our traumas. So tell us a little bit about that. Like, how would you explore that with a patient in a way that addresses the medical component, but also this sort of bigger aspect of well-being?
I first became aware of these disorders, like irritable bowel syndrome is sort of the most commonly recognized one, because I work with patients with inflammatory bowel disease, so Crohn's disease and ulcerative colitis. So those are very devastating, high burden illnesses, often onset in childhood and early adulthood, that are chronic. There's no cure for Crohn's disease, and the only cure for ulcerative colitis, which is located to the colon, is resection, is a surgical intervention. And so these are very challenging diseases to live with and cause a really high burden of psychosocial distress. It's related to poop, and they're not sexy diseases to have. They can be very stigmatized. And what I found in working with these patients is often that their symptoms that they were having and the flares were not always correlated with when their disease was actually acting up and when they had the highest inflammation in their gut that we could see on endoscopy or colonoscopy. And that often patients were in clinical remission, endoscopic remission. So we couldn't see anything inside them, but they were still having debilitating symptoms. And then of course there are people who don't have these diseases like Crohn's disease and ulcerative colitis, but they're living with illness and chronic symptoms, but our current medical tools we don't have the ability to figure out what the mechanism is of these disorders. So, these patients, so maybe you're having chronic abdominal pain, and you present to a doctor and you're really debilitated, you're having diarrhea, you can't eat. The doctor does a workup, they get labs, they do all the things that they were educated and learned how to do. And the workup comes back negative. And these patients are told, you're fine, nothing's wrong with you. And instead of feeling relief from that, these people who are suffering with an illness that their doctor is telling them there's nothing wrong, they feel completely invalidated. And they feel that no one understands what's going on. There's no hope for fixing what's going on. And maybe they'll go to another doctor and they'll get another workup. And the stress and the anxiety around their symptoms gets higher, and then their symptoms get worse. And they feel more invalidated by the healthcare system. And what's going on subconsciously is these symptoms, these real phenomena, which they're being told are not real, end up magnifying, their pain thresholds go down, and these people can become really debilitated. So these are the patients who I love to work with, these patients who've been told that there's nothing wrong with them, but they're still suffering on a daily basis. And what we know are some of the best treatments for these disorders are a long-term therapeutic doctor-patient relationship. So a relationship, being validated, told that what they're experiencing is real. And then things like some antidepressants, or we use the term actually like neuroleptic medications or neuromodulators, because a lot of the medications like SSRIs, SNRIs that we use are they're not inherently antidepressants. We use them for depression and anxiety, but the mechanisms of these medication are not specific to those things. And then because depression and anxiety are stigmatized in our society, people with brain gut dysfunction get stigmatized or they feel stigma around taking an antidepressant for a GI symptom, because then they think they're crazy. It's all in my head. And of course, we shouldn't have such stigma for mental illness, but all of these factors play a role into a patient's lived experience with abdominal pain, and what really is a brain gut dysregulation, mediated oftentimes by the vagus nerve, by intestinal bacteria, and an unhealthy microbiome from an infection and so forth. So these things are really complicated, but to distill it, it's that having a doctor tell you that, so these patients who have doctors that tell them what you're experiencing is real, it's not anything scary, you do not have Crohn's disease, you do not have cancer, and we're going to work together to make a plan that works for you. That's one of the best things that we can do for our patients who are suffering with these conditions.
Yeah, I had Dr. Vora on a while back, and she talks a lot about this as well in terms of this more functional medicine approach. And it's hard to find a functional practitioner. I mean, it's not easy finding people to do what you're doing, but it would be very relieving to have a doctor that's willing to work with you on it, but not pathologize you for it or give up on you, right? So, can you talk a little bit about like how that works for you? Because when we started this call, you said I'm working nights, and I often wonder about this, and even just for myself as a psychologist, we're talking about all these ideal things, and in your life, there's stressors. There's times when you're not sleeping. There's times when you're not eating well. There's times when you're not exercising. There's times when your relationships are just sort of not going well for whatever reason, and you're stressed. How do you apply some of these principles of positive medicine for yourself?
And that is life, right? It's like the second things are really smooth and going great. And then, Ruth Bader Ginsburg dies, right? I remember that, and not to get into that, but that is life. Like that is inevitable. So as you said, I'm working nights. I'm working nights right now. It's only a week, but it's so disruptive to my sleep schedule. And, I find myself hoping that I'm not going to get called in my little call room because that means I have to get out of bed and go see a patient, which is exactly what I've signed up to do. And then what's so interesting is the second I go and I see the patient, I feel that sense of, this is my calling and this is what I'm here to do. But it's crazy.
This is what a parent feels. Same thing. You hope that your child isn't called, but then when you actually go in and you talk to them, you feel like, oh, this is what I'm called to do.
Exactly.
To comfort you at night.
But I think what's so important, and to have that ability to really see the big picture, like when your sleep is disturbed, it's to make sure, like, when I get home, I have those hours to rest and make up for that sleep that I lost. I feel so grateful that I have a partner who is like, can cook me dinner and be a partner when I do not have the capacity to do those sorts of things. So, today I decided I was actually going to stay at work and sleep an extra hour rather than come home at the end of my shift, because I knew I needed that hour to be more refreshed today so that I could actually come home, get a workout in, take a shower, and then have this phone call and then get a little rest in before I go to sleep. So sometimes it's about, just really listening to your body and what you need instead of defaulting to, okay, I'm going to go right home. I was like, no, I need that extra hour today. Physical activity is huge for me. And, having my own therapy is huge for me too. When I started my psychiatry residency, my program really encouraged us to get our own providers. And so for the last 2 years, for the first time in my life, I'm seeing my own psychiatrist, who is my therapist. And I see her twice a week, 45 minutes twice a week. And that is absolutely a priority. Sometimes I have to take my appointments from my office on Zoom. And I have a white noise machine and I put it on in between seeing my own patients. And it's something that has been just a huge part of my own growth as I've started to be a doctor. And it really helps me with my own patients.
Oh yeah. Doing your own therapy. It helps to be on the other side of the couch or chair or whatever. And there's a moment where you have to also let go of trying to figure out what they're doing. Like, what intervention are you using right now?
Like, what are you writing down? What are you writing?
Just let yourself, feel the benefits of the therapy and the relationship. And there is this danger, right, in whether it's positive medicine or positive psychology, of perfectionism and all of this, and the idealized, drinking your green smoothie and eating your kimchi and exercising and getting 8 hours of sleep and maximize it. That in itself has become a new problem for folks, especially high achievers that want to do everything right. So I like what you're saying there around you have some foundations, but you have flexibility within those foundations, and really adapting from moment to moment, day to day, on what's the best thing. Like, some days it may be not to exercise because you are so physically depleted, and other days exercise may be the best thing to get you moving and get you out of whatever mind state you're in. So that's great. One of the other things that you talk about quite a bit in here is strengths. And I had my good friend Alexis Karasbachik on a while back, who studies some of her research is in the VIA and strengths. And I loved how you're putting together, and I think this is important, like putting together, identifying what your strengths are and identifying your values, and then how you are living those out on a day-to-day basis. What are some of your strengths and how do you use them?
Sure. So I've been taking the VIA survey now for years, and my top 3 are always the same. Love, the capacity to love and be loved, is always number 1. And I think that is love is like the centerpiece of my life, with my relationships with my family, my husband, my colleagues, my patients. Love is like so critical in there. Not like romantic love necessarily, but really a loving orientation, a compassionate orientation towards life. So love is always my number 1. My number 2 is always wisdom, like perspective, trying to see things from, multiple sides. And I think that's going back to the first question about that role I played in my family. I think being the baby of the family and just watching all the dynamics play out, I think that was a big part of my childhood growing up. And then I think that number 3 and 4 kind of change a bit. Most recently, it's been gratitude as my number 3, and hope is a close fourth. So hope and optimism. Do you have a sense of what your top strengths are?
My top two are consistently kindness and love as well. And then interestingly, related to my first comment earlier on, my lowest is bravery, courage. And what I actually, this is what I talked to Alexis quite a bit about, was how sometimes things that are low on our strengths list are also can be some of our values, and then we can work on them. You know, it may be that it doesn't come innately to you, but you really value it. And if it's low on your strengths list, so folks can take that inventory, but if it's low on your strengths list, it doesn't mean it's not something that you can build in your life. And actually, it feels kind of good to work on a low strength activity. It's actually an opportunity for mastery.
It totally is. You
can kind of work at it over time. So do you remember what was low on yours?
So I think spirituality tends to be low for me on the VIA because it's a lot about like religion and like specifically God, but I actually do really consider myself a spiritual person. So I think it has something to do with the way the questions are phrased, and how I answer them. And then, I think prudence is pretty low down there. I've become more of like a risk taker in, my adult life. It's really funny, actually. Bravery is one that I used to be quite low for me. And so I did this practice with my co-residents, actually. We introduced this to my whole class of psychiatry residents, and we spotted strengths in each other. And like bravery was like my modal strength. My classmates, my peers see me as being very brave, and it's not something at all that I ever thought of myself as. So it can be so interesting to see how different strengths come up in different contexts and how different groups of people perceive us. Because I guess in residency, like I'm always one to speak up and teach my classmates some positive psychology things. And I was like leading the session on strengths. So it was really cool to like see that discrepancy between how I view myself and how others view me.
Right. Yes. If you were to ask my partner about kindness on some days, I might not score so high, even though it's one of my strengths. So yes, these things, context matters with our strengths too.
Matters, yeah.
Yes, absolutely. So that is learning to harness our strengths. And that's very much part of, I would imagine, positive medicine too, because when you can get a sense of what your patient's strengths are, then you can start to help them apply that to their physical health or whatever intervention that you're wanting them to, to get started on.
What was so surprising to me, I was once doing this strengths intervention in a group of folks who like have really serious mental illness, and were in a partial hospitalization program, many of whom were like had recently attempted suicide, and they were recently out of the hospital and transitioning to outpatient life. And I was so pleased with, like, I went in with really low expectations. I thought people who were really down on life and just emerging from near-death experiences would not necessarily be able to pick out strengths. And everybody was able to pick at least one strength that they really saw within themselves. And it was like so transformative. Instead of talking about like how we're coping or like what makes it hard and how we're just getting through day to day, like we were talking about like our strengths with like people who are really depressed. And it's just amazing how like it really proved to me that like the presence of the positive and building well-being is really orthogonal to mental illness. Like these things are not the same, and they're not the same spectra. Like these things intersect and they're correlated, but I think we need to do more of this stuff, building the positive, working on strengths, especially in people who are really experienced in the throes of mental illness.
Yeah, well, we see this in the education system. We see this in parenting. We see it in organizations. When you are highlighting people's strengths, then they grow those things. And oftentimes we just have this older model, which is a punitive, pathologizing, problem-based model. So seeing people as problems. And if you start to believe that you are a problem, then you will take that as, it's a bit of a, confirmation bias there too. So absolutely. And sometimes it requires us to just put on a different lens for ourselves and for each other and look for those things in each other and then verbalize them, say them out loud. So, yeah. So your strengths, I'm noticing you have a great strength at being able to just be like humble, tell story, but then like pull research out of nowhere and really weave in and out with me very organically in this conversation. Those are some of your strengths that I'm noticing. Another section that you talk about is exploration and being curious. And you talk a bit about ACT in there as well, psychological flexibility. How do you work with, if you are working with folks that are struggling with depression or maybe anxiety, we see their lives getting pretty narrowed. How do you work with people on starting to explore the edges?
I think part of it is helping them realize like where they may already be doing this in their lives. Like even for someone, I'm working with a lot with veterans right now at the VA, and it's a really high like PTSD. PTSD is very prevalent, and a huge part of PTSD is avoidance. And, the whole idea of expanding our comfort zone is refraining from avoidance and really understanding how we can expand our worlds. Someone's not going to go from being afraid to leave their house to like go and, asking someone on a date in a coffee shop, but really like working up like baby steps, having them really pre-think like what might come out of this? Like what are, using some motivational interviewing skills, like, let's say like your desire to like get out of the house and, come for your appointment is a 5 out of 10. Like, why isn't it a 1? What is it that you might get out of coming in today and having this conversation in person? So really helping folks like tap into their own motivation and navigate their own ambivalence and really see the possibilities, and really also helping people think about times when they faced a fear in the past. Often the anticipation of doing something that seems scary or out of our comfort zone is often so much worse than actually doing it. And like having folks think of examples of like when that was true and thinking about when they faced a fear, like what happened, like how good did that feel? And then what were they capable of doing after that?
Yeah. Sometimes I'll have folks, I use sticky notes often in my practice, and I'll have folks write down a value that they want to pursue this week. So it may be a value around physical health, like maybe they want to have more physical activity, and what is it they value about that? And then put that on their mirror. And in the morning, looking at it while you're brushing your teeth, and just look at that value and remember why this is important to you, and like really let it sink in. This is important to me because and then, by afternoon, it may have kind of lessened or whatever, but at night, go back and brush your teeth again and remind yourself all the times that you actually lived out this value today. And that becomes the reinforcer as opposed to all the times that you didn't. And you can actually find some time. I mean, even if it feels like you really didn't ever do it, if you look hard enough, you will see that you actually
lifting your arm to brush your teeth.
Yeah, you're brushing
give yourself credit.
You walked to the mailbox, you whatever, and how'd that feel? You shifted your position a little bit, whatever it is. So that's where we have to kind of get our head around, again, not pathologizing, but looking for strengths, even that can be a motivator or a reinforcer to get you out of your comfort zone. And then the other trick, there is this whole thing around tiny habits, which I am a big fan of, and small moves, but I'm also a big fan of big leaps when your motivation is high. So when your motivation is high, that's when you go for it. You go all in. You buy the tickets to the concert that later on your motivation is going to be low, like an hour before, and you're tired and you don't want to go, but you already bought the tickets. So whatever it is, when you feel that motivation wave, that's when you act on it. And then you prepare yourself for when your motivation is low to be able to make those small, little, tiny moves to keep at it.
I love that. That's really helpful. I think I'm hesitant to encourage people to do big change. So that's helpful for me to reconceptualize a little bit.
Yeah. Well, sometimes I think we underestimate ourselves.
Yeah.
And we underestimate each other, and we have to give room for, you can make a big change and then you can backtrack a little bit. But unless you try, you won't know. Okay. So we're close to the end on time, and I want to ask you 2 more questions, 2 more big talk questions from your list here. And this whole list is in your book, Choose Growth, so people can pick it up there if they want to use some of these big talk questions with their family members, friends, or partners. Are you ready? Okay. So when did you last cry in front of another person or by yourself?
Oh, I cried like happy tears this past weekend when I was with my group of high school friends for one of our friends is getting married, and we did a bachelorette party here in New York City. So it was right before I started night float. So it was like Friday night into Saturday, and I went to night Saturday. And just there's something about being with your oldest friends in the world. We were just cracking up, like tears streaming down my face at dinner. I don't even know what, but there were tears. I was definitely crying with my girlfriends.
That's great. Yeah, there's different types of tears. There's tears because something sad has happened, and there's tears because you've been touched by something, by a strong emotion. And that is, just being touched.
And just a quick caveat on tears, like what a more potent example of the mind-body connection of something emotional happening, whatever it is, and then having this weird, like our eyes start watering, our nose starts running, like it's a totally physical experience. So if anyone is doubting that the mind and the body are connected, tears and crying are totally like an amazing example of it.
Yeah. And communication, like our ability to communicate. Okay. So I'm going to modify the dinner guest because I'm so tired of the dinner guest question.
Okay.
And I'm going to ask you a modified one, which is good for a psychiatrist because you've probably been in this position that I've gotten into many times, which is the airplane seat partner. Because when you're on an airplane for 5 hours and you have the wrong person next to you, you're kind of stuck with them. Who would you want, if it could be anyone in the world, to be on an airplane for 5 hours with, sitting next to talk to?
Honestly, I know this sounds so lame, but I think I would want it to be like my sister because my sister is my best friend, and she used to live in New York. Now she's in the burbs, which is like no excuse to not see her all the time. She's a mom now, and our time together, I recognize that our one-on-one sister time has gotten so much less over the last couple of years, and we need to be better about that. But I would love an excuse to sit next to her for 5 hours without anybody there and just be together. And so it's not anyone famous, although she's famous to me, but I think it would have to be my sister.
That's a great answer. It really shows your strengths of love and your values there. Both of those answers show about relationships and why you put that first in your revamp model.
It's definitely the most fundamental to my being. Yeah.
Good. Well, thank you so much, Jordyn Feingold. Dr. Jordyn Feingold, it's been a delight to have you on. Sleep deprived, you are on it. Even your brain's amazing. And I hope that people will pick up Choose Growth, and they'll also just follow you. And I'm so glad that you're out in the world training our future physicians and making a difference in the way that you are. And I will continue to follow you as well because you're just fun to talk to and learn from.
Thank you so much, Diana. It's been a pleasure. You're amazing.